Well, hi everyone. Welcome to today's Alaska Collaborative on Health and the Environment webinar. This is our last event for 2022. So thanks for everyone who's joined us throughout the year and yeah, made it here this morning or this afternoon, wherever you're calling in from, listening to the recording later. We appreciate you taking the time to learn and join us on these important subjects for Alaska, for the Arctic, for the nation and the world. Our session today is entitled Per- and Polyfluoroalkyl Substances, or PFAS, and their health effects. So this is in particular focusing on addressing the National Academy of Sciences and Engineering Medicine's recommendations for at-risk populations. I'm your host, Nick Reardon. We're calling in, as usual, from Alaska Community Action on Toxics office here in Anchorage, Alaska. These are the traditional and unceded lands of the Dena'ina people, and me and my coworkers, we continue to be very grateful to past and present stewards for this wonderful place that we call home. For those of you new to this webinar series, the Alaska Collaborative on Health and the Environment, it's a regional partner of a national collaborative on health and the environment. And so we abbreviate it CHE or CHE, and so CHE or CHE Alaska, and there's other CHE partners. We're all working together to advance knowledge and action related to the links between human health and environmental factors. So we try our best here at CHE Alaska to talk about and pay attention to issues of particular importance to Alaskans, to Arctic communities. So I invite suggestions. What are environmental health issues and concerns important to you? What would you like to learn more about? Reach out. We also maintain a list of topics and recordings from past CHE Alaska teleconferences, as does the National CHE, so you can check that out on our website. There are literally decades of webinars on important topics like this one. And special thanks to Alaska state legislators and their staff who could join us today. We really appreciate you taking the time. We know you've got a busy schedule. So on to the topic for today. We are so grateful to be joined by Dr. Laura Anderko, who is the co-director of the Mid-Atlantic Center for Children's Health and the Environment. She has a wealth of experience in public health, having worked as a nurse for over 40 years, an educator and scholar for over 25 years, with a focus on environmental health. And so there's links to several of her more recent PFAS-related publications in our resource list, and I encourage you to check those out if you haven't already. And what brings us here today, though, is that she's a co-author on a recent NASEM report, that's the National Academy of Sciences, Engineering, and Medicine, entitled The Guidance on PFAS Exposure Testing and Clinical Follow-up. So yeah, without further ado, Dr. Anderko, please take it away.
Thanks, Nick. Thanks for the invitation, and welcome to everybody who is joined us today. And I'm just going to double check. Can you see that all right, Nick? All right, thank you. Just a quick commercial and acknowledgement. The Mid-Atlantic Center gets funding through a cooperative agreement from the American Academy of Pediatrics. It is funded primarily through the CDC ATSDR. We do get some partial support from the US EPA. And of course, anything that is mentioned does not imply endorsement. Although I must say this report was paid for, the NASEM report, primarily from CDC ATSDR. We are part of a national network. I know Mary Kate from Region 10 had signed up. I don't know if she's on today. And that's the section in the top left of the map that is that serves Alaska. I am from Region 3, the yellow section. It seems as though my slides are moving on its own. So, all right. Today, we're going to discuss the NASEM PFAS report findings and recommendations. We're going to briefly discuss per- and polyfluoroalkyl substances. I suspect many of you on the call already are familiar with them. We're going to talk about exposure pathways. We're really going to focus on Alaska in some of our discussion today. We're going to look at health effects and recommendations made by NASEM related to prevention of exposures, and we're going to touch on federal and regional resources. So the NASM report was published in August of this year. The statement of task for the committee was the following: basically, to review the human health literature of health effects, to look at principles for biological testing and clinical evaluation, particularly under substantial scientific uncertainty for many of the PFAS chemicals, to really look at human exposure pathways and look at principles for reducing those exposures, providing advice to CDC ATSDR for clinical guidance, and a strategy to keep it updated, to provide recommendations on blood testing, and to provide recommendations on patient follow-up. The link for the free report is below, or you can just Google NASM PFAS and it'll take you right there. What was unique and novel about this committee work and this report were the three items on the screen. The first was that we designed an ethical framework and principles for clinical practice, given the level of uncertainty and, quite frankly, the ever-changing sort of landscape of research findings. They were still changing as we were finalizing the report. And so how do we guide clinicians' practices during a time when things are shifting pretty quickly? It was informed by community voices. So although we looked at research findings in depth, we also included the qualitative aspects of what we heard from the communities. Pam Miller, who's invested in this group and works hard towards Alaskan policy, environmental health policy, was one of the informants. And I will speak to a little bit of what she said in a minute. And then finally, the environmental justice framework, and we'll touch on that a little bit, full knowing that much of the EJ issues are systemic. We wanted to put it out there to make sure people thought about, both policymakers and readers of the report, that this was something that needs to be addressed at a much higher level than localities or states. So what's new in the report? Those of you following PFAS, particularly for clinicians, know that there was a time when we said we don't recommend testing because we don't know what the outcomes are going to be. It's expensive. There's a lot of reasons not to get people excited and worried about getting their blood tested. This report changes that perspective. So this report recommends that clinicians offer testing for PFAS for patients who are likely to have a history of elevated exposure. I apologize. I'm not quite sure why my screen is doing that. And to help clinicians understand how to interpret the results and follow-up care. We also looked at existing research and we rated the health outcomes based on how well supported it was by the science. And we outlined recommendations to CDC ATSDR on how to update the guidance. So what are perfluoral alkyl and polyfluoral alkyl substances? We know that consists of a large family of 12,000 plus chemicals. They are short or long chain based on the number of carbon atoms they have. They are designed to be water resistant, grease resistant, and they're very durable. They're not easily eliminated by the body, and they are considered forever chemicals or legacy chemicals. Why is this important? Well, we know that 98% and more of us are walking around with one or more PFAS chemicals in our serum. There's widespread human exposure. We do know, and we'll talk about these findings for health effects, that they may affect the developing fetus and child. They may increase cancer risk. They do often bioaccumulate in people. They are long half-lives, which we'll talk about in the next slide. EPA has coined the term contaminant of emerging concern, and we'll talk a bit about EPA's actions over this past year in regards to the escalating findings in the research studies. And then finally, we know that PFAS levels exceed EPA's lifetime health advisory levels in drinking water in several states. And this slide was developed when the lifetime health advisory was at 70 parts per trillion. It's now far lower. So I imagine there are many, many more states that exceed EPA's lifetime health advisory in drinking water. So how long do PFAS remain in the body? Well, the shorter chain tend to stay shorter amounts of time than the longer chain. We have PFBA, which can stay from 72 to 81 hours, and PFHXS from 4.7 years to 35 years. We also know that when there is a national action taken, such as there was many years ago now, where the EPA had asked chemical companies to voluntarily stop production of PFAS, that those levels come down. And interestingly, it also reduced the disparities in exposure, which is something to think about when we're talking about EJ issues. How does PFAS enter the environment? This is really important as we think about Alaska. We obviously get exposed through the primary production of these chemicals, especially folks living downstream, also through atmospheric release. These are applied as biosolids on agricultural fields like sludge. We use them in commercial products and in products we purchase, like nonstick cookware. And in Alaska, and especially the AFFF firefighting foam has been a large contributor to the contamination in the drinking water. Also, there are issues around leachate release and landfills, which is a problem here in Alaska as well. So this is a map of Alaska. Keep in mind that Alaska is a really large state. It is not like Delaware or Illinois or Virginia. It is a huge state. And so when we see these green marks, it should compel us to think long and hard about the level of pollution and contamination that's occurring. I want to read briefly a couple quotes. Pam Miller was from the Alaska Community Action on Toxics, was a community speaker at one of the town hall meetings. And she talks about Alaska's strategic military importance has resulted in the establishment of multiple military installations across Alaska that have used AFFF firefighting foam. She also explained that Alaska is a very aviation dependent state, with this type of foam being used in airports situated directly adjacent to communities and their water sources. She also highlighted the importance of flight to transport, to get from one place to the other because of the size and the remoteness of the state. And so that also compounds the airports and the foam that is used within these airports. She highlighted the particular plight of Alaskan remote regions as a hemispheric sink for persistent organic pollutants like PFAS. These receive undue burdens of mobile pollutants as a result of global distillation processes that transport the pollutants to remote areas, including PFAS. She shared the results of a community-based study in an indigenous community on the island of St. Lawrence in the northern Bering Sea, which showed the blood of community members that were reliant on traditional diets of polar fish and marine mammals, with 13 PFAS in their blood of 85 people. And the levels correlated to select PFAS that can result in thyroid disruption. So it's a real serious issue. So we can be exposed in a number of ways. It's this family of chemicals is very ubiquitous. We can be exposed by contaminated drinking water or private well water, eating fish or wildlife that is caught. There was a study done fairly recently in hunted wildlife deer up in Maine and found extremely high levels of PFAS in the deer meat. We could accidentally swallow it from contaminated soil or dust. Keep in mind that the products that we purchase, like carpets, clothing with these chemicals, over time, flake and dust, create dust in our homes and can remain in those areas for a long, long time. We may eat food grown or raised near places that are used or made PFAS. If you saw the movie Dark Waters or The Devil We Know, both available on many streaming platforms, you'll see that there was an issue with the cows that drank PFAS contaminated water in their milk. This is just one example of many, many examples of how PFAS can get into our food supply. We may eat food packaged in material that contains PFAS. Think French fries, grease-resistant packaging, for example. We may use consumer products such as stain-resistant carpeting, water-repellent clothing, or nonstick cookware. We also know that PFAS and PFOA are commonly found in breast milk and cord blood. It usually is between 3 and 10% of what's in the mom's serum. There's still a lot of research going on to look at long-term effects, but we know that it passes through the placenta. Women are more likely to have lower levels of PFAS chemicals. We're thinking because of menstruation and breastfeeding, which is a mechanism for eliminating this group of chemicals. So what are the health effects? The ATSDR on their website list the traditional, what we know is our pretty commonly studied outcomes related to PFOA and PFAS and some other chemicals. We've seen increased cholesterol levels. We've seen changes in liver enzymes, small decreases in infant birth weights, decreased vaccine response in children, increased risk of high blood pressure or preeclampsia in pregnant women, and increased risk of kidney or testicular cancer. So what the NASM committee did was there was a several step process as we reviewed the literature, and we started with authoritative reviews such as the C8 panel reports. There were European Food Safety reports, EPA, NTP, ATSDR, and we looked at, we compared all of those, and then we looked at systematic reviews that had been published, and then we reviewed recent epidemiological studies. And I would refer you to page 58, 59 for more detail on sort of how many articles and why we selected some and not others. We decided not to use animal studies for this report. Then we synthesized the evidence. We started with the ATSDR's tox profile and took the results from our study review. And then we used Hill's framework based on Hill's consideration, which many of you may remember from epidemiology, biological plausibility being one of those, and then came up with a mechanism for structuring each one of these findings. So The first category is sufficient evidence. And what this means is sufficient evidence of an association, meaning that it was most likely not due to chance or bias. And we found, consistent with what had been found before, a decreased antibody response, both in adults and children. I believe Philippe Grandjean did a webinar on that around COVID and PFAS and uptakes of vaccines and the real risk that we run if we have too much of these chemicals in our body. Dyslipidemia or high cholesterol, adults and children both, decreased infant and fetal growth, and an increased risk of kidney cancer in adults. The next category was limited or suggestive evidence. This could have been due to bias. It wasn't quite as strong as the last group. One of the surprising findings was an increased risk of breast cancer in adults, which had not been documented up to this point. We also saw, consistent with earlier findings, liver enzyme alterations in both adults and children, increased risk of pregnancy-induced hypertension, and an increased risk of testicular cancer. We also found an increased risk of thyroid disease and dysfunction in adults, and an increased risk of ulcerative colitis. All right, well, I guess I got to go this way. So finally, the last category was inadequate or insufficient evidence. This doesn't mean that there isn't an association. It doesn't mean that it's not going to change as we get more research. But given the criteria we used and the systems we used to review, all of the things that we've already said, the cardiovascular outcomes, for example, the dyslipidemia. Outside of that, there were no other symptoms or outcomes based on this list that you're seeing here as yet. So one of the big charges and tasks of the committee was blood testing and clinical follow-up. As I said earlier, clinicians were advised not to encourage people to get blood testing. There was no way to really compare that level with a level of risk, quite frankly. And the committee looked at after reviewing the literature and looking at the data, decided that actually people who are highly exposed should be encouraged to get a blood test. And then we needed to look at potential clinical follow-up measures by the clinicians based on those lab values. Before I go into that, I do want to talk briefly about the ethical framework that we use, because as we're moving into discussing that clinic visit, there's been a lot of angst from both sides, both the patients and the clinicians, about, well, what's the right thing to do if we're not sure, right? Because we're continuing to get this research, but there isn't anything definitive. And so we came up as a committee. We happen to have a phenomenal ethicist on the committee, Dr. Kevin Elliott, who helped guide us through the thinking of this framework. And so we came up with these 5 principles: autonomy, proportionality, feasibility, adaptability, and justice. The autonomy is basically to allow the patient to have shared decision-making with a clinician, to be able to feel independent in saying, I really want the test. I know you don't think it's going to be helpful, but I feel like between my work environment, or I live near a military base, or I eat the fish in the water, I think I want this test. And so this really underscored the importance of shared decision-making between the clinician and the patient or the family. Proportionality was really looking at the benefits and the harms of having the test done. In any testing situation, there's always some level of harm beyond the stick in your arm. Some people were worried that if they got the test and it was high, that might, and everyone in their neighborhood did it, it may reduce their resale value of their home. They may not, have as much value in their home, or their neighborhood may be earmarked, whatever. So there's harms and benefits to all tests. And this just recognizes that each individual community and family, that needs to be weighed, the pros and the cons. The feasibility really links with justice in many ways. The feasibility is really how feasible is it to get the test? Right now, there's only a handful of labs that do the test. The report lists those very specifically. And we're getting news that there are more labs that are opening up to do this testing. Right now, it's about $300 to $600, and a lot of insurance companies don't pay for it. So it's a huge burden. And when we're thinking about justice in EJ communities, these are communities that are carrying the burden, are living in these communities, are being contaminated without their knowledge, oftentimes, and then they're carrying the burden of having to pay for the healthcare and the screening and all of that. The last principle is adaptability, and that really is both for clinicians and for CDC, ATSDR, to keep in mind that the research keeps coming in, and we need to be able to be flexible and adaptable based on those findings. The last thing I wanted to share real briefly is the EJ framework that we used by Pello. This really, we felt that this was important. We were told many times as a committee, our charge was not to address policy, which for many of us was really hard. And so we decided to, in addition to the ethical framework, is to couch these recommendations in an acknowledgement that there are a number of EJ considerations when we look at PFAS. The first is the socio-historical process and the context. Many of these communities, particularly those that are overburdened, there's a history of systemic racism. There's a history between the industry and these communities, these relationships that were set up decades ago. This is difficult, right? This is difficult. And when we talk about the complex roles of those involved, we have folks that work in those industries. They have family that worked in those industries. The community depends on that for their economy. So it's just not saying, well, don't work there. It may be the only game in town, right? And so there are these complex roles and embedded within this socio-historical context that sometimes makes it really difficult. Number 3 is the effect of inequality on stakeholders. One example of that is this whole idea of fishing for subsistence. In Alaska, that's a reality. That's a real reality. Some of it is because people can't afford it. Some of it is, it's part of their culture. Some of it is combined. I'm working with a community in Hawaii where Pearl Harbor, there was a fuel tank leak, and these folks fish for subsistence and because it's part of their culture. And it's hard. It's really hard when we're telling people, well, just, don't eat the fish because it's, it's got a lot of PFAS in it. We have to help people find alternatives or solutions to help them. And 4 is agency. And agency really is, part of it is the agency and the power of the community to advocate. Part of it is the agency itself, the politics and how the policy is or isn't supporting what the people want. And that goes back to 1, 2, and and 3 in some ways, about these complex relationships between industry, and I include military and industry. There's many people employed by the military, and they don't have a choice of where they live. And so we need to think about all of these issues, and they're really detailed in the book, in the report, pretty well. So this you need your reading glasses for, and I'm going to walk you through this. I wanted to use exactly what was in the book, in the report. So let's start at the bottom, which is anything less than 2 nanograms per milliliter PFAS is, you're okay. It's not that high. It's sort of like, you know, the CDC setting lead at 3.5. Even though we know there's no safe level, we're not gonna start our hair on fire if it's, 3. Then we move into the area where the majority of people land, which is between 2 and less than 20 nanograms per milliliter. Basically, what we're saying in the report, and I do want to preface this, that CDC ATSCR is currently looking at these guidelines with a fine-tooth comb and determining how much of this they agree with, how much they may tweak. They've talked to clinicians and gotten feedback about some of the recommendations. So, but basically, if you land within that range, the recommendation is to prioritize screening for dyslipidemia, which most of us have, a lipid panel once we get to a certain age. But they're also recommending children get it, to screen for hypertensive disorders during pregnancy. Again, this is a usual standard of practice, but if somebody has a high level of PFAS, this would red flag it for the clinician to keep an eye on it, and to screen for breast cancer based on clinical practice guidelines, based on age and other risk factors, such as a family history. The top one is for people over 20, and the general statement for all of these is to, number one, do an exposure assessment and see where the exposure to the PFAS may be coming from, right? If it's from consumer products, we can modify those using those. If it's from your drinking water, that gets more complicated, of course. And if we're eating fish from highly contaminated water, that becomes more complicated. But in addition to the usual standards of care, there's a recommendation to prioritize screening for dyslipidemia if your levels are 20 or higher, and to conduct thyroid function testing to assess for kidney cancer and testicular cancer and ulcerative colitis. So what are the public health and clinical implications? We know that PFAS has been detected in the blood of most people in the United States, indicating that the exposure is widespread. I want to underscore that Alaska has a lot of hotspots, and it is a huge state. There are some PFAS that bioaccumulate and have long half-lives. The research indicates that exposure in humans may affect many organ systems. I want to refer you to the recommendation section in the report, particularly 6-3 for the clinical management. PFAS have been detected in many drinking water systems across the country at levels that exceed the EPA lifetime health advisory, putting populations at risk. Again, those were lowered. We're going to be looking at those in just a minute. The best health strategy, obviously, is prevention of exposure. And we did look at some therapies like phlebotomy that seem to be promising, but not enough to recommend them. We also need to keep in mind that reducing or mitigating the risk of disease really involves not just reducing PFAS exposure, but looking at other exposures and other disease risk factors. So how do we reduce PFAS exposures? My slides have a mind of their own today. So first of all, drinking water filters. This gets back to the justice issue. These can be pretty expensive in order to, so you need activated carbon or reverse osmosis filters. This is not the water pitchers, right, that are $30. So for a lot of families, this is not reachable. There are many communities within the US that are looking at their water treatment systems, looking at filtration, but these are expensive as well on a much grander scale. If folks are feeding their babies formula and they have contaminated PFAS water, to use pre-mixed formula or to use water that you know is safe. I always laugh when I get to this bullet, dust control in home. Like, really, I never had control of dust in my home, but okay. So if you know you're living, if you may have atmospheric pollution from a nearby factory, or you have a lot of stain guard carpet that might be flaking off, be more vigilant about controlling the dust in your home. Check local fish advisories, and I would also say wildlife / hunting advisories. Many health departments are beginning to test for this in both fish and wildlife. Avoid certain consumer products. The next slide just refreshes our memory about that. And test garden soil if you're using water, and this was in the report from your group, Nick. There are agricultural concerns, and not just with sludge, but with water that's being used that's contaminated and being used for agricultural purposes. So just a reminder, reducing the use of some of the consumer products that we've become very comfortable and familiar with will go a long way. So some of the federal and regional responses, we know that the Biden administration last year began to move to curtail some of these chemicals. And the CDC ATSDR has been active in doing both health and exposure assessments. I did pull up some of the results for Fairbanks, which was one of the areas tested. The exposure assessment found that the level of 2 PFAS, perfluorohexane sulfonic acid and perfluorooctane sulfonic acid, in the blood of participants was higher than the national average. And they also looked at water, and all Moose Creek drinking water samples collected met the action of the Alaska Department of Environmental Conservation action levels from the private wells that were tested by the Air Force in Moose Creek. So the ATSDR is recommending that residents continue to use the alternative sources of water provided by the Air Force for now. ATSDR is also updating the clinical guidelines. As I said, they're in the process as we speak of hammering out more detailed recommendations for clinicians around kidney cancer and testicular cancer. The EPA, as I mentioned, back in June of this year, 2022, released updates on 4 PFAS for their health advisories. PFOA and PFAS are interim right now, and you can see it's gone from 70 parts per trillion all the way to 0.004. That's incredibly huge difference. And there is money through the Inflation Reduction Act, for example, to help fund communities to get their systems in place to filter out some of these chemicals. So last but not least, focus on some of the legislation that's pending in Alaska. There's a Senate Bill 121 and a House Bill 171 that is really looking at requiring responsible parties to test for perfluoral and polyfluoroalkyl substances in all drinking water when a PFAS substance is released in the area of the water supply. It also allows the state fire marshal to adopt regulations requiring the use of alternative PFAS-free firefighting foam and establishes MCLs for PFAS in drinking water. And then finally, Alaska is one of a few states that its state attorney is pursuing litigation against the manufacturers of PFAS chemicals for contaminating water supplies and other natural resources. Finally, I want to invite you, the Region 3 Mid-Atlantic Center for Children's Health and the Environment is having a series of webinars. The next one is in January. We are recording them. They're on our website here in the lower left-hand corner. I do want to point out in March 15th, Pam Miller will be speaking on a focus on the EJ communities related to PFAS. And we end with some of the recommendations that NASM provided to improve public health. So in summary, there's widespread human exposure. Exposure in humans may affect many organ systems. Prevention of exposure is the best health strategy, which really, as we can see from the past, comes from policy initiatives. And blood testing is recommended for highly exposed people. And I didn't mention this, but I'm going to mention it now. This is a photograph I took while I was in Glacier Bay in Alaska. I've been to Barrows and throughout the state as a Sierra Club outings leader and member. And it's one of the most beautiful places you ever want to be, ever. And I leave you with that and thank you. And we'll entertain some questions.
Thanks so much for that presentation. That's really well appreciated by the audience too. And there are some questions here. Okay. Let's see. Right off the bat, Joseph Braun asks, what do you think will be the key challenges to getting PFAS testing integrated into clinical practice? And what can we do to help move this along?
Hey, Joe, how are you? Great question. We talked about that at length at the committee. Again, because we were not able to talk about policy, but we did talk about integrating it into electronic health records as a cue to action for the clinicians, particularly in highly contaminated areas, just to remind clinicians that this is a question they should be asking, right? And so that would be one way. Another way, of course, is educating health professionals about this. You know, nurses and physicians are not trained in environmental health. That is not a requirement to sit for the boards. And so the majority of health professionals have no idea of the connection between environmental exposures and health. And this is an EJ issue for sure when we start thinking about rural communities with limited health access and the people that are providers may be working in heavily contaminated areas and don't even have a clue that this could be causing some of the health issues that they're seeing in their clinics. So I would say those two in particular. You know, there was discussion about fellowships, money for fellowships. We actually also made a big pitch for better funding for the public health system nationally, because, you know, COVID really kind of decimated people's faith in public health, and the funding has, you know, public health departments have been really decimated. And really don't get enough funding for the work that they do. We know that it's when it's broken, but we don't know when it's working. And it takes money and personnel to keep oversight and to make sure that our water is drinkable and people aren't getting sick. Great question, Joe.
Here's another one. Sarah Casper asks, so what do we do if both the state and federal agencies are in denial? The community is exposed for decades, has never been told about the toxics that they're exposed to, even though an agency should know that certain industries commonly use PFAS, but basically no sampling for PFAS has occurred.
So I would, well, I'm thinking about the square, the 4-box square for EJ and the agency piece. Now that there's a report out and there's town hall meetings with people that have been impacted, that are really quite compelling, young people that have cancer and health issues, it's all there. And that could be just a link that you send to a policymaker, or you write an op-ed in the paper, or a letter to the editor and say, listen, I saw this webinar, or I saw this report. Hey, the Biden administration is doing this. What are we doing? Are we going after this money? There is a lot of money to be had. It's a lot, and it's flush, and the timelines are always ridiculously short. But now's the time to sort of, blow the horn and say, this is an issue nationally. We know this because EPA is on it. Let's do something about it, and work your advocacy muscle a little bit. I would first start with the report, which is a highly respected organization, NASM, and then the town hall meeting clips are really powerful. And the stories, the transcripts are in the back of the book as well, in the appendices.
Thanks. Mervyn Wright asks, how dependent is our society upon the continued production of PFAS or PFOS? What is it going to take to stop the production? How much data is needed to convince us of the danger?
Wow, that's a great question. So it's in everything, but we know that, for example, when PFOA was voluntarily taken off, there were new ones in the ready, right? They're shorter chain. We don't know as much about the shorter chain, which is a problem. We have a chemical policy that doesn't require testing for human health effects before we include it in food and products. And so that's a problem. There was a great lecture by Carol Kwiatkowski, I think through your group, Nick, on categorizing chemicals, which is a fantastic webinar if you can watch it, because it really simplifies when you're talking 12,000 chemicals and you're like, it's like whack-a-mole, right? So you're like, okay, we got rid of this one, now we've got 10,000 more, and we don't know anything about these 10,000 more, and then it's 20 years later when people start getting sick. So do we need them? Sometimes we do, and there's been research to look at which ones we have to have and which ones we don't have to have. And so that's a great question, and we need a whole nother hour to talk about it. But there are people looking at that very question and saying, why don't we just get rid of the ones that we don't have to have and take the ones we have to have and work on those, on alternatives for those?
Wonderful. There's another question here. Are there any concerns about occupational exposure and health? I don't know if this becomes an OSHA issue.
Yeah, it's a huge issue. And I refer you to that film, The Devil We Know, which really, it's a documentary about a woman, sort of the canary in the coal mine, who was pregnant and was exposed and gave birth to a child with a number of disabilities. And yes, it's absolutely an occupational issue. And we talk about in the report, this being a group of people that are considered highly exposed, that work in any of the industries that create the products we love. There are a number, we know the classic companies like DuPont and 3M, but there are other companies producing these for Hush Puppy shoes in Michigan, for example. The military uses AFFF foam extensively. That's why Alaska has all those hot spots. And so, yeah, occupational exposure. We heard from a woman whose husband died and was a firefighter and was exposed to high levels of this AFFF firefighting foam. So yeah, occupation is huge. We did talk about in our report that if somebody believes they've been exposed occupationally, they need to use the OSHA mechanism. And it's detailed in the report, but it's an important consideration when you look at exposure assessment.
Thanks. And yeah, you mentioned the previous presentation. Yeah, Carol Kwiatkowski. Yeah, regulating PFAS as a class, and I'll in addition to other resources that are coming up in this Q&A, I'll do my best to add those to a follow-up email with a link to the recording of this for folks. I saw there was a link in your slides too to upcoming webinars, and I'll go back and get that from the slides and include that for listeners too.
All right,
there's some interest. Another question here is about duration of exposure. They asked, so the military facilities and other facilities, they may have been there up to 50 years versus another individual who maybe was only exposed for weeks or months. Is there how does length or time factor in?
Well, in any chemical evaluation, dose and time exposed is super important. And not all of these chemicals act the same. Some are long chain, some are short chain. So yeah, that all matters. And that's why the exposure assessment is so critical. Whether it's done by a clinician or whether you sit down and think about what you consume, whether your drinking water has PFAS in it, all of those things. Yeah. So dose and the quantity as well as the length of time is super important. And some of these are bad actors because they're long chain and they bioaccumulate much more readily than the shorter chain.
Along the line of bioaccumulation, there's a question from Kyle Robillard. Consumption of contaminated fish is a potential exposure pathway. Are you aware of any studies looking at concentrations in Alaskan salmon?
No, but that's a great question. I know that fish consumption and PFAS have studied pretty well in the Northeast. So the hot spot when the issues around military bases started was really in PEASE, PEASE community, and people started testing water and then testing fish. And I know a number of states have tested for PFAS, like Michigan. I don't know about Alaska salmon. That's a great question. I'm going to look it up when we get off. That's a great question.
Yeah, I know there's certain toxic chemicals that are, that get stored in animals' fat, and I'm not sure if PFAS is one of them. So I don't.
No, it binds to the tissue. It binds to the tissue, so it makes it harder to get rid of it. So it's not like you can skin the fish and broil it and get rid of it like PCBs. It's in the fish tissue, so it's really hard to get rid of it. And I know that Pam, as part of her commentary, talked about the lack of testing for fish and wildlife. That was a year and a half ago, so I don't know if anything's been done since then, but that was something that she pointed out as being there's nothing being done, and so many people eat fish to for subsistence and because of their cultural beliefs. So she was talking several times about that, actually, that there's no testing going on.
Yes, you mentioned those two bills, but there's a question. Tamala Trussell asks, do you feel we should be asking for legislation to ban the class of PFAS? And I'll extend, state legislation or federal. Yeah.
Mm-hmm. Yeah, and that's where Alaska, those two bills come in. I mean, they're not banning it per se, but they're saying if you spill, then you're responsible. And the state attorney is looking at suing the producers of it. So I think during this administration in the White House, I think it could get some legs on it. And I think that I know there's a lot of work going on behind the scenes to sort of correct the errors that were made earlier in earlier administrations and not wanting to worry people. And so sort of, hiding the reports and the science. So I think now is the time, particularly if you live in an area that has been contaminated by PFAS, now's the time to go local, state, and national and federal and let your voice be heard, for sure. Now's the time.
Yeah, I think many of us will agree with you there. George Steinharm is writing to us to say, yeah, PFAS is fat soluble, and that explains its persistence in humans, fish. So
okay, I did not know it was. Oh yeah, it's lipophilic. You're right. It's and lipophilic, and it binds to the tissue as well. Thank you for correcting me on that. You're right.
Yeah, thanks, George. Getting into the weeds here, but it's an important distinction.
Yeah, it is.
Let's see here. Well, this is an anonymous speaker here, but how do we convince our government to have toxicology follow the use of chemicals in foods and other exposures?
So is that for health professionals, or is that for educating health professionals, or?
I'm not sure, but yeah, I think for this talk, that makes sense.
So the interesting thing, and we do address this in the report, is that medical and nursing education in particular are not bound by any federal regulations, right? So there are independent organizations that offer the state boards and determine what should be on the state boards. I have met over the years with folks in nursing state board organization, and unless you can make a really strong case that it's an important issue, it's not going to be required. And if it's not required for the boards, then it's not going to be a priority for the educational institutions. So that's unfortunate. We do know that there was a decision made by the accrediting organization for public health that environmental health was no longer a requirement. And so even folks that get an MPH these days may not get environmental health as part of it. So it's a private industry. I think maybe the government could come in and say, we want you to do this. Why not? But right now, that's not how it's organized. And so folks are not being educated on environmental health at any level, maybe lead, but that's about it.
Yeah, that does sound like a deficiency. There's another question here from Tim. Do community members have a right to know when their neighbor, coworker, or fellow consumer is experiencing a large chemical trespass, regardless of how certain the health risks are?
It depends on what state you live in.
Yeah.
That's all I mean, it really varies. And, you're more likely to have protections if you live in northern states and southern states, but not necessarily. And it depends on the chemical. There's a lot of lobbying around every individual chemical from every industry. And so it depends.
And yeah, there's a clarifying comment in the chat here for those who haven't seen it, but in terms of the two bills that we're talking about in Alaska, that those those were introduced last session, the 2021-2022
Right.
legislative session, and they'll be reintroduced. Kind of fortunately, but also unfortunately, they did not pass, and
Right.
so Alaska continues. Alaskans continue to work for regulation, and
There's a good, I'm forgetting the name of the website. There's a few actually where you can track that legislation and see where it's at, and if there's anything new coming up. And I would, for anyone interested in advocating or doing education for policymakers, I would recommend just, Googling it and having it sort of alert you when things are moving, because sometimes these things go really quickly, and you don't have a lot of time to prepare. So proactive is always the name of the game, if you can do it.
I'm just going to throw out one more question here and then sign off to respect everyone's time. But where's a good place to look for PFAS testing of blood for 1,000 citizens near a huge industrial complex of 11 major industries?
Say the first part of that
Sure.
again.
Where's a good place to look for PFAS testing of blood for, they say, 1,000 citizens near an industrial complex?
Wow, that's a great question. So the report lists those companies. If you email us, I think my email was on the last slide, our center email, we can send you those lists. But they're they're listed, the names of the companies are listed. If it's 1,000 people and it's from a company that did it, you may be able to work with your local policymakers to see if they would offset the costs. I know DOD paid for a lot of testing in the Northeast when when they first discovered the high levels of PFAS at Peace. So there's I would not pursue having the polluter even pay for some of it. And if you have 1,000, you might get a discount. I hate to say it, but and the test costs are coming down. I've talked to some lab folks that are getting in the business, and they're looking at really reducing rates and becoming more competitive with the other ones. So, yeah.
Well, thank you again for that really informative presentation and for your work on this report. And there's a lot of appreciation coming in through the chat as well from the audience. And there's a recording of this, and so I'll send out an email later today with a link to that recording. It'll be up on our ACAT that has a J-Alaska webpage with a webinar archive as well. And I'll do my best to add additional related resources there. And so again, thanks everyone for joining us. Thanks to our wonderful speaker, and bye for now. Have a great rest of the day.
Thanks, Nick.
Bye.
Bye.